Good morning. Just on my way to work. This is December. I'm on my palliative care rotation. Pretty much sitting in traffic right now. It's just a little before 8, so hopefully I'm not late to work. And as you can see, I'm bundled up and it's dark outside and it's like 8 o'clock, which is winter, which sucks. I wanted to maybe vlog a little bit throughout the day just to give an idea of what I'm doing on a palliative care rotation and how this kind of inpatient hospital rotation goes. It's a little bit more of a, slow-paced, chill type of environment, so it might be a good example of what we do while we're in hospital. Yeah. Okay, hi again. I completely forgot that I was supposed to vlog today, which is so unfortunate because it was such an interesting day, and so much stuff happened, so I'm really sorry, but hopefully tomorrow. I'll just go over quickly some of the stuff that did happen today that was so unique. I saw my first pronunciation of death, I guess is what you would call it. So where someone actually died. We saw him in the morning. He looked very unwell. He is basically someone with metastatic lung cancer and was requiring a lot of respiratory support just in order to breathe, and we just didn't expect it to happen so soon. But it basically, we were sitting reviewing charts for other patients, and then I guess it was a matter of maybe an hour and a half later that we were just informed by the nurses that he had stopped breathing and didn't have a heartbeat anymore. This is like palliative care. I don't know if this is different in the sense that it's not the way that I expected it to be on TV, where the resident needs to be there right away in order to pronounce them, and be like, time of death, blah blah blah, 10:04 a.m. It wasn't anything like that. It was just going in, assessing the patient, and listening to their chest to see if there are any heart sounds, checking to see if there's a pulse anywhere, and if not, then you just, that's that. Yeah, that was the one interesting case. And then the other interesting case is actually the patient that I'm following, who is very, very sick, and you just looking at him, he looks devastatingly ill, and I can see how it's so hard on the family. They're from a poor country and they've come here, and the wife is just so angry and frustrated at the husband for not being able to eat. And we have explained to her time and time again that at this stage in his advanced cancer, eating is the last thing his body is thinking of, or probably can't even process food and calories the way that we would, or the way that it would be helpful at all. So she just kept insisting, for the past week. That's the main issue that I've been struggling with, and convincing her that please do not force feed him. This is only for his pleasure if he does want to eat, and if not, if you force feed him, there's a much higher chance that he aspirates, which is where food goes into your lungs and you get a pneumonia. So it seems like over the weekend he became even less responsive and declined further. So I think as of this morning, they were all a lot more accepting of the very imminent death. And I have a feeling that if it didn't already happen, that it'll happen overnight or by tomorrow. It's interesting for me, sad for the patients obviously, but unique experiences for me. Really, really touching just to be in the room with that family as the attending staff was talking about the fact that he will probably imminently die, and just to be more accepting of it. But he did it in such a beautiful, nice way, and brought it back to faith, which never ever happens in medicine. Honestly, I feel like there is never an opportunity to talk about your faith in God, and the preceptors talked about it in just such a sweet way, and talked about faith in God, talked about how this patient is the family is Christian. Obviously he wouldn't do that if they weren't, or if they were non-practicing, but they are. So he was just talking about how this person will be happier when he's back where he came from, or from home, or however you like to put it. And that seemed to really comfort the family. So it's obviously going to be patient specific, but I just was so humbled to see how he dealt with it, how he even brought faith into it, which I never see anymore. And just to be a part of that intimate moment with the family was really a privilege. Hey again, everybody. So this is day 2 where I'm going to try to actually record this vlog. So we just came in at 8 o'clock, did a handover, so just heard from the nurses the updates on everybody overnight. Unfortunately, the patient that I was following, who I expected to pass away, did pass away overnight at about 2 o'clock this morning. So for the morning we have to, I guess, assess him, pronounce him, and then I'll write up the discharge summary for that, and then in the meantime see the rest of my patients. Alright, so it actually turns out that they took the patient away to the morgue already because this happened overnight, and I guess with the nursing staff they just assessed him, and it was very clear that he had passed, so they didn't need physicians, I guess, the physician to assess them right away. So the patient is gone, and I'm kind of sad just because I didn't get to see the family. This was a family that I had talked to extensively, you know, over the course of the past week. So it would have been nice to have that closure and just, you know, express how sorry I am for their loss. Unfortunately, didn't get to say my goodbyes to the family, but I'm still glad we had this really long, detailed chat yesterday about just, you know, spirituality and the meaning of death and all of this stuff. So that's that. Right now I was actually sitting down to do his dictation summary that just goes through his course in hospital, and there obviously won't be a discharge plan, so this is how this is different from a normal discharge summary, because in the case of the deceased, they're not going to go anywhere. For other patients, you would have a detailed plan of what they need to do after hospital and follow-up and medications and that kind of thing. This is more for medical record purposes, so just need to make sure there's no patient information in there, but this is the chart. I'm just going to get started on the computer, and then you dictate through the phone there, and I'll check in back later. Oh, and this is what it looks like outside right now. Just completely white. I hate winter. Okay, so I just finished that dictation. I saw my patients already, did the mini mental status exam that we wanted to do, and I'm just gonna go for lunch. Got a book this time because I've been like sitting usually during lunch, which is like an hour long, just sitting on my phone instead of reading a book or doing something useful. And yeah, and then at 1 o'clock we go back and we do team conference, which is where all the different allied health specialties, so things like physiotherapy, occupational therapy, spiritual care, all different kinds of services that we, like interdisciplinary services that we consult to, are all going to sit down and talk about the patients. That usually goes like an hour and a half or 2 hours. So we just go briefly and discuss the relevant issues for everybody. Yeah, that's this afternoon. Okay, so I just got home. It's 4:40-ish, and it's like sunset outside because it's winter time. For the rest of the afternoon, we actually didn't end up having team conference today. I read up on my admission that's going to be coming in tomorrow, and that seems like a really sad case. It's a young female with really metastatic colon cancer, so it's going to be really a tough day for me tomorrow. I just started reading kind of her background history, and then tomorrow I'll actually get to talk to her once she gets to the hospital. And yeah, it'll be interesting tomorrow. Okay, so this is the next day, and I did do that admission. Um, the the lady who came in, it is a really sad story, and um, she's quite delirious and confused, so I can't really get anything from her. But from what I understand from the husband and then her friend who's with her, it's just been a really long journey for them. And something really interesting happened today, actually, in this case. Because of everything that's happened, and more recently, they had, like, the hospital that they came from, she had a really acute decline. But 2 weeks ago, she was her normal self. She was active, walking around, even doing like physical activities, extensive physical activity, despite being on chemo. So she obviously was doing really well, even on chemo, and even despite the assault that has on your body. She suddenly had this acute decline, and she is no longer on chemo because they've just determined that it's not effective anymore. So the fact that this all happened within the time frame of like 5 days, not even, makes me really feel inclined to like treat this as a delirium or something. And there could be a million factors in play here. And she could, I feel like with supportive treatments, she could do fine, and she could do well for herself. Because her decline was so severe when she got to the hospital before being transferred to us as the palliative care, less acute side of things. Because of what happened there, they actually made her into what we call goals of care in Canada of a C2, which is the most comfort care or compassionate care with absolutely no medical intervention. Nothing that will prolong life at all. Only comfort, only pain medication type of thing, and only other measures like anti-nausea medications, that kind of thing. I really had a hard time accepting that. And when I talked to the family members about that, they said they felt very pressured into making that decision, making her from a more higher level of care. For example, something like an M1, which is medical management. They would treat someone if they got an infection or pneumonia. They would give you antibiotics. They would try to, like, if you suddenly spiked a fever, they would try to find the source of that fever. They would do all those necessary investigations. For somebody like this, who's a young, previously healthy, aside from this devastating illness that has, I understand, really taken over her body, I feel like she is appropriate for something like medical management. I'm not saying she should get CPR. I'm not saying she should go to ICU, but I just feel like because this is such an acute change for her, that she deserves to have, thorough investigation and see what actually caused this sudden decline. I mean, I know it has something to do with the cancer, but what specifically? So that was my whole take on it. When I presented the case to the staff physician, he really disagreed with me. And he he was quite hard on me. And even the residents afterward told me, like, we're impressed that you actually stood up to him, and he was harder on you than he should have been. In the end, he ended up talking to the husband, and he did end up convincing him to make her a compassionate level instead of C2. I at least pushed for a C1. But it's just his whole approach, the doctor's whole approach in this case, just made it hard for me to digest, because there are patients on our service who are M1s who shouldn't be, who are like really on the brink of death. She, as such a young person with a body that is still trying to fight off the cancer, believe it or not, I feel like she could very well benefit from some of the things that we might do that would include, like, blood work and chest x-rays and stuff like that. So I could just feel, for the first time really in my short little career, I've had this like severe pushback from a doctor who really disagreed on a principle and just kept emphasizing the fact that she's in denial. She's in denial, even her family's in denial about how bad this disease is, and she's not competent to make decisions. And I just, like, I couldn't get over the fact that, yeah, she's not competent right now, but in her previous orders and previous documented discussions, she stated very clearly that she wants aggressive management. So that made today very interesting. It means that I'm going to have lots to talk about during my residency interviews, because this is exactly the kind of stuff that they ask you, is like, when did you have a conflict with a team member, and when were you a patient advocate, and when, when did you try to communicate and collaborate and stuff like that. So I'm going to have lots to say based on this one patient case. I am proud of myself for at least trying. I definitely made a case for her, and I said what I need to say. At the end of the day, I don't control it, and the only thing I can really do is support the family as best I can and answer their questions. If they do, I mean, the decision is up to them. They are lay people, and this is what happens, is that you just follow the advice of a doctor. So when this husband asked the doctor, what do you think we should do, of course that person's going to take the doctor's advice, and definitely not mine. I'm a fourth-year medical student. So I'm just going to be as supportive as I can, and we'll see what happens. I hope she's still around tomorrow.